Good,
Good morning, good afternoon, good evening, dear colleagues, wherever you're joining us from. A warm welcome to this special NTB webinar organized jointly by the World Health Organization and the TB Europe Coalition. The webinar is focused on multi-sectoral engagement to address the social determinants and key drivers of the TB epidemic, and it is being moderated by uh,
channel, please switch off the original audio as well. You will also be able to review slides in any of the three languages. I will explain how to select the slides language just before the first presentation. And now it is my pleasure to invite Hannah Monica Diaz, cross-cutting lead WHO Department for HIV, TB, hepatitis, and STI for opening remarks. So Monica, the floor is yours now.
Thank you so much, Yulia. And after that initial quick introduction, it is my great pleasure to welcome you formally to the second webinar in this global NTB webinar series that we are holding as the World Health Organization and TB Europe Coalition on operationalizing the WHO Multisectoral Accountability Framework on TB, looking at moving from planning to progress. Today's session brings together, as you can see, over 100 people, partners, practitioners, policymakers, civil society, communities to advance a shared commitment, accelerating multi-sectoral engagement to address the social determinants and key drivers of the TB epidemic. As you all well know, a substantial proportion of the global TB burden is fueled by five major risk factors under nutrition, HIV, alcohol use disorders, smoking, diabetes. These risks intersect these risks basically intersect with a wide range of vulnerable populations and high risk groups, including prisoners, women and children, people who work in the mining industry, indigenous populations, migrants, refugees, healthcare workers. These are just a few of the high risk groups that I have listed here. Now, addressing these realities and advancing the NTB response, especially in these challenging times of funding cuts and crises, multi-sectoral engagement is a priority. We need to work towards overcoming, these challenges of poverty, inequality, the broader social and economic context with close engagement across sectors. WHO, with close partners like Tibet and civil society, continue to champion and support this engagement through the WHO Multisectoral Accountability Framework for TB, ensuring that the response extends beyond the health sector alone. Over the next 2.5 hours, we will explore how countries and partners are catalyzing action and drive on TB drivers and determinants through MAF-TB, or the Multisectoral Accountability Framework on TB, through its implementation. We will hear how strengthened collaboration across social protection, labor, justice, nutrition, and other sectors is helping accelerate progress toward our common goal, ending TB as a global public health threat. I wish us all a productive session and hand back to Yulia. Thank you.
Okay. Now you should hear me well. Uh, today's webinar is an interactive one, and we have scheduled 2 discussion segments as well as time for Q&A with speakers. And between segments, please feel free to post your questions or comments in the chat and do indicate which speaker you are addressing. And please keep your microphones muted if you are not speaking, and do not share your screens. And my colleague will now share the technical instruction on how to see the slides. And before we move to the first presentation, just a brief note how to view slides in your preferred language. In the top of the toolbar under shared screens, select the appropriate screen. So you can see you should see a presentation in Russia, presentation in English, and presentation in French. Dear colleagues, can you share the presentations so that people can see how it works? Because now we do not have presentations. And please, the Russian one, dear colleagues. So now, as I said, you should see on the top of the toolbar under shared screen, select the appropriate screen, presentation in Russian, presentation in English, or presentation in French, meaning you will see the slides in the corresponding language. And as I said, detailed instruction should be already in the chat. And if you have any issues, please write in the chat and we will respond promptly. So now it is my pleasure to invite Katie Vinny, team lead HIV, TB, hepatitis, STI associated comorbidities and drivers, WHO Department for HIV, TB, hepatitis, and STI, to speak on advancing implementation of WHO guidelines on TB drivers and determinants. So Katie, please, the floor is yours. Thank you.
Great, thank you, Yulia. And I just want to check that you can hear me, Yulia, and that everyone online can hear me.
Yes, we can hear you.
Perfect. Thank you so much. Well, firstly, thank you, Yulia, for the lovely introduction, and to the TB Europe Coalition, and of course to Monica and colleagues. It's great that WHO is able to partner with the TB Europe Coalition for this series of webinars. So as mentioned, I'm going to talk about advancing the implementation of WHO guidance on TB drivers and determinants. I won't have time to cover all of the WHO guidance on this area, but I'm going to focus on a few areas during this presentation. Next slide, please. So firstly, the NTB strategy, of course, does emphasize action on addressing the drivers and determinants of TB, especially in pillars 1 and 2, but of course, pillar 3, intensified research and innovation, is also highly relevant. So here we've got pillar 1, which is about early detection of TB, systematic screening of contacts and high-risk groups, treatment of all people with TB, providing treatment support, collaborative TB HIV activities and management of comorbidities, and preventive treatment and vaccination. Just next tab, please. And pillar 2, if you can tab on the slide. Yeah, great, thank you. So pillar 2, of course, is also relevant, where we have the components of political commitment with adequate resources, engagement of affected communities, civil society, and all care providers, which is what we are here for today. Social protection, poverty alleviation, and action on the other determinants of TB, as well, of course, universal health coverage and the necessary regulatory frameworks. Next slide, please. Now, great. So, of course, I think many of the people on this webinar are aware that the political declaration arising from the United Nations High-Level Meeting on the Fight Against TB firmly recognises the fundamental role of the drivers and determinants of TB. And I won't read out everything that's here on the slide, but just to say there is recognition in the political declaration that TB disproportionately affects people in vulnerable situations in all countries, and that the epidemic is driven by certain determinants, which are listed here on the slide, and that these determinants and socioeconomic consequences of TB are also exacerbated by specific situations, such as humanitarian emergencies and armed conflicts. Next slide, please. Now, fortunately, the United Nations High-Level Meeting political declaration goes beyond merely recognition of the problem, but it commits to action. So here, the political declaration says that it commits to comprehensive care for all people with TB, using specific models of care which are listed. And today, during this presentation, we're going to focus on a couple of specific areas of care for which we have WHO guidance, and namely that is the 3 areas in blue. So social protection, people in prisons and other closed settings, and people who are undernourished. Next slide. So we have good data to show that action on the drivers and determinants of TB matters. And these data are reported every year in the Global TB Report, and we'll soon see the new Global TB Report with the most recent data. This slide just shows that access to healthcare is fundamental to addressing TB. On the vertical axis, it shows the percentage of the general population facing catastrophic health expenditures. So the higher is higher catastrophic health expenditure. And then on the horizontal axis, it shows the health service coverage index. You can see that Thailand is closest to having the highest indices, so the lowest costs and the highest health service coverage index out of the 30 high TB burden countries. And of course, universal health coverage is an important driver of TB, or lack of universal health coverage, which is also a feature of this slide. Next slide, please. Now, there are other indicators also in the Global TB Report which emphasize the importance of the determinants and drivers of TB. This slide just shows one of the socioeconomic determinants, and it is referring to the proportion of people who face catastrophic costs due to TB in various countries. And catastrophic costs is defined as spending 20% or more of annual household income on the TB diagnosis and care. So if you can imagine spending 1/5 of your annual income on a TB diagnosis, this is certainly catastrophic as it's defined. Now, the average for countries who have done a catastrophic cost survey is about 49%. So 49% of people are facing catastrophic costs. And this is even higher for people with drug-resistant TB at 82%. So this is certainly another determinant of access to TB care. Next slide, please. We have other data also in the Global TB Report, and Monica mentioned this in her introduction. So we record the attribution of TB to 5 main health-related risk factors, and these are here on the screen. So they are undernutrition, alcohol use disorders, smoking, HIV infection, and diabetes. And you can see the relative contribution of these 5 health-related risk factors. And I'm going to talk a bit more about undernutrition throughout the next few slides. Next, please. Great. Also in the Global TB Report, we have evidence that the TB incidence rate is strongly associated with average income levels. So that's the panel on the left of the screen with the green line, where you've got GDP per capita on the horizontal axis and TB incidence on the vertical axis. So as GDP per capita increases, TB incidence decreases. Then the figure on the right-hand side of the screen is the association between TB incidence per capita and the prevalence of undernutrition in any given country. And you can see that there's also an association between higher levels of undernutrition and higher TB incidence. Next slide, please. Now, as Monica mentioned at the start, multisectoral accountability is important for addressing the drivers and determinants of TB, because there are health-related risk factors that drive the epidemic, but of course many of these determinants and drivers lay outside of the health sector, so multisectoral accountability is certainly important. Next slide, please. Now, going on to the topic of today's talk, I'm going to speak briefly about WHO's guidance on the drivers and determinants of TB. And as mentioned at the start, I won't have time to touch on all of our documents in this area, but I'm just going to focus very briefly on 3 areas. So the first is TB and undernutrition, the second is TB and social protection, and the third is TB and prisons. Now, on the slide here, you can see the guidance on social protection for people affected by TB, which was published in 2024. You can also see our guidelines on tuberculosis, in particular TB and comorbidities, and an undernutrition section was added to this guidance and published just last month in October 2025. And we are also in the process of developing WHO guidance on the programmatic prevention and management of TB in prisons. So I'll talk a little bit more about that. Next slide, please. So firstly, as I mentioned, undernutrition is a key driver of TB. There's about 1 million episodes of TB are attributable to undernutrition. And in the Global TB report, we publish for each country the burden of TB that is attributable to undernutrition, which is included in the little heat map at the bottom of this slide. Next slide, please. And as mentioned, WHO has just released new guidelines on TB and undernutrition, and it is in this consolidated guidelines on TB and comorbidities. The new guidelines supersede the previous guidelines. I think many people on this call will know of the previous guidelines. And the new guidelines were informed by WHO commissioned evidence. So we commissioned 3 main systematic reviews to answer questions of public health importance around TB and undernutrition. We commissioned some background reviews. We also did a survey of national TB and nutrition programs in high TB burden countries, and we did interviews with TB survivors and household contacts. Oh, I now can't see my slides. Oh, they're back. Okay. And this evidence was assessed by a WHO convened guideline development group meeting in 2024. Next slide, please. So what has happened since this guideline development group meeting was held is we've obviously issued the guidelines last month. There are 9 recommendations on TB and undernutrition in the guidelines. We probably don't have time to go into the detail of all of those recommendations today, but perhaps I can just highlight very high-level points and highlight some of the new recommendations. So firstly, WHO has recommendations on nutritional assessment and counselling, as you can see here on the slide. There is one recommendation for people with TB who should be offered nutritional assessment and counselling based on their nutritional status. And then the new recommendation is that household contacts of people with TB should be offered nutritional assessment and counselling as part of contact tracing. And if undernutrition is identified, it should be managed according to WHO guidance. Now, in the guidelines, we've defined both nutritional assessment and counselling. And you can see here that nutritional assessment includes the anthropometric measurements, it includes biochemical assessments, a clinical assessment, and a dietary assessment, as well as assessment for any underlying pathologies. Next slide, please. Now, in terms of the other recommendations, we also now have a new recommendation on nutritional interventions to improve clinical outcomes for people with TB. And this is recommendation 3 that you can see here on the screen. So that says that nutritional interventions should be offered to people with TB who have severe, moderate, or mild undernutrition as part of a comprehensive package of TB care. And severe, moderate, and mild undernutrition are defined in the guidelines, so you can see how they're defined. And this recommendation was made based on a systematic review, which identified 17 trials of nutritional interventions. The balance between the benefits and the harms were assessed, and this balance in terms of benefits was in favour of high energy protein food, arginine-rich food, food vouchers, and financial support, plus psychosocial counselling. And this evidence showed that the nutritional interventions have a positive impact on TB outcomes, nutritional outcomes, and also performance outcomes. Next slide, please. Now, moving on with the recommendations in these guidelines, we've also included some recommendations from our treatment and care guidelines. And these are recommendations on nutritional interventions to reduce loss to follow-up of people with TB. So to provide a package of treatment adherence interventions which may be offered for people on TB treatment. And for these TB treatment adherence interventions, it can include material support, which can include the provision of food. So there's just that recommendation on adherence support as well. Next slide, please. In terms of the other recommendations, we have a new recommendation on food assistance to prevent TB in household contacts. And this is recommendation 6 that you can see here on the screen. So in settings of food security, food baskets in combination with multiple micronutrient supplements should be offered to all households of people with TB. And this was this recommendation, the evidence that informed this recommendation came from the rations trial, which was identified through a systematic review. And we're very fortunate to have Professor Bhargava on this call, who I'm sure will talk about the rations trial, that it showed that there is a relative reduction in TB incidence of 39% among households who receive food assistance, and therefore this new recommendation has been made. Next slide, please. There is also in the guidelines a new recommendation on vitamin D supplementation. This is a recommendation for research, not for programmatic use. So you can see that vitamin D supplementation may be provided to people with TB, but only in the context of rigorous research. And then finally, we have 2 TB screening recommendations, one for people with clinical risk factors who are seeking healthcare, which includes undernutrition, and one for people with structural risk factors for TB, which includes food insecurity. So they are the 9 new recommendations in the guidelines. Next slide, please. And these are all available on WHO's TB knowledge sharing platform. So you can see the web address there for that. And we are in the process of producing a complementary operational handbook, which will contain practical guidance on how to implement the recommendations. Next slide. So moving on to social protection now, and I believe we'll have a great presentation on social protection as well in this webinar. But we know from the evidence that social protection has several effects. It increases the chance of TB treatment success. It may reduce intra-household transmission by half, and it also cuts catastrophic costs by 1/3. So we have published evidence for all of those statements, which is available here on the slide. Next slide, please. And of course, poverty, lack of access to healthcare, and lack of access to social protection are drivers and also consequences of the TB epidemic. We have this target here arising from the political declaration for the high-level meeting on the fight against TB, that people should be covered with a health and social benefits package, and that target is 100% by 2027. We also have an NTB strategy indicator that the percentage of TB-affected households facing catastrophic costs due to TB should be 0% by 2025. And you can see that last year in the Global TB Report, we were far off achieving the target where the percentage was 49%. Next slide, please. Now, in terms of what the WHO guidance is, as mentioned, WHO issued guidance on social protection for people affected by TB in 2024. We've defined social protection because sometimes it's not well understood, but social protection really refers to policies and programs that are designed to prevent and reduce poverty, vulnerability, and social exclusion throughout the life course. The right to social security, which is sometimes used interchangeably with social protection, is reflected in the Universal Declaration of Human Rights. And in the guidance, we recognise that the social determinants really shape the epidemic, and social protection works well to improve outcomes, and lack of social protection is in fact a driver and determinant of TB. Next slide, please. The guidance, we don't have time to go into the detail of the guidance today, but this is just the content of the guidance. So it contains information on social protection for people affected by TB. What are the concepts? What is the definition? What are the potential impacts? We talk about how to plan social protection programs for people affected by TB, the implementation of both TB sensitive and TB specific social protection programs, and both of those are defined, as you can see on the slide. And finally, the guidance contains information on establishing and sustaining multisectoral collaborations between TB and social protection. Now, we're currently in the process of developing some additional tools for baseline situational analyses of social protection, so they will be coming out in the near future. Next slide, please. And finally, just a few slides on prisons as well. So we know that TB in prisons is a driver of TB. It may even be a driver of community outbreaks as well, and that people in prisons and closed settings are an at-risk population for TB. The burden of TB disease in prisons is about 10 times higher than the general population. And in 2019, we know that about 125,000 people in prisons fell ill with TB, which is about 1% of the global incidence. Incidence is high at over 1,100 per 100,000 person years. And we know that there's underdetection. So about half of people with TB in prisons were detected. WHO published a featured topic on TB in prisons in 2023 that was published alongside with the Global TB Report. And we have started collecting data on TB notifications in prisons from all regions. Previously, they were collected in the region of the Americas and in the European region. Now we're collecting these data from all regions, and this figure on the right is from the Global TB Report in 2025, which just shows the percentage of people notified who were registered in prisons by country. So these data are continuing to be collected. Next slide, please. So, of course, we have a number of recommendations in our guidelines and operational handbooks, and all of these are relevant to TB in prisons, assuming that healthcare in prisons should be the same as that in the community. However, we do have some specific recommendations on TB in prison. So next slide. And those specific recommendations are firstly on prevention, where systematic testing for TB infection and treatment may be considered for people in prisons. And next slide. And another recommendation on TB screening, where systematic screening for TB disease should be conducted in prisons and penitentiary institutions. We provide some information on when that screening should be done, and we also have a number of screening tools in our guidelines, so they're included there. And of course, TB and screening in prisons should be combined with screening for other diseases, including HIV, hepatitis, and health promotion activities. Next slide, and I just heard the timer, so I'll wrap up. Just in terms of what WHO is doing, as mentioned at the start, we are developing programmatic guidance on the prevention and management of TB. We issued a call for case studies on TB in prisons in August 2024, and we received 47 case studies, so that was a very good response. And yes, we are preparing this guidance. Actually, just last week, we held a stakeholder consultation on TB in prisons, and we're moving forward with publishing this guidance in early 2026 after external peer review. There is some regional guidance as well from the region of the Americas, so you can see that listed on the screen, and that's guidelines for the response to TB, HIV, STIs, and viral hepatitis in people deprived of liberty. Next slide, please. And I think that's it. Yeah. So thank you very much for listening. It's been a quick run through of some of WHO's guidance on TB and undernutrition, TB and social protection, and the forthcoming guidance on TB in prisons. I'd just like to very much thank all of the colleagues who are listed here on the slide, including our director, Dr. Teresa Kasayeva, and everyone who has contributed or led the relevant documents on TB in prisons, social protection and undernutrition in order to improve the lives and also the livelihoods of people with TB or at risk of TB. So thank you very much.
Many thanks, Carrie, for the overview and for introducing such useful WHO resources, because the more we understand the key drivers and determinants of TB, the clearer it becomes that multisectoral action is essential to address them. So thank you again for the rich presentation. And I will pause a slide. I will ask my colleagues to pause slide sharing. And we are now opening the floor for questions and comments to Carrie. So please use the raise hand function to ask the question, or if you want, please share a brief comment in the chat. So dear colleagues, now it's your time to ask the question. Please raise the hand or write your question to the chat. So while people are thinking, Katie, can you hear me well?
I do, yeah.
So are you expecting the translation of the guidelines that were presented into different languages?
We do. For many of our guidelines, we're translating either the whole guideline or specific sections. So yes, we do expect to do translations.
Okay, thank you so much. And when you're expecting the full data for the prisoners, because you were saying that there is no full data right now, so when?
We do have full data for last year from all regions. So we have the number of TB notifications who were identified in prisons for last year. With the new global TB report that will come out, we'll have updated data. But we started collecting data for all regions the year before last. So we had those data in the global TB report 2024. So going forward, we will have data for all regions, whereas previously that was for 2 regions, the region of the Americas and Euro. But now all regions are being asked to provide those data.
Okay, thank you. And we have one question in the chat, Kerry. So Yves Habimana, would you like to say it or should I read it? Okay, so TB in prisons. The people in prisons are at high risk of TB. How could you exclude the active TB among prisoners for TPT initiation while these people are continuously exposed to the risk of TB?
Yeah, it's a good question. Well, we do have a recommendation on TB screening. So, so when prisoners, enter a prison, they should be screened for TB, and obviously TB disease should be ruled out before they would be eligible for TPT. That TB screening can be annually. And of course, I think there needs to be a high level of vigilance and awareness of TB at any time in the prison. So if someone is identified with TB between the rounds of screening, which can be the case, there would need to be contact tracing around that person, and then some of those people may need to be offered TPT. So I think it's a matter of TB screening on entry, TB screening regularly, and then TB screening when needed if someone is identified with TB, and providing TPT as appropriate and as recommended in the WHO guidance.
Okay. Thank you so much, Kerry. I see that people feels more comfortable writing comments in the chat. So what if the recommendations are conditional and or the evidence are of not great power?
Yeah, that's a good question. I mean, a conditional recommendation is still a recommendation from WHO, so it may not apply to every setting, but it's generally, it's still a recommendation from WHO that can be taken up by countries. If the data, I'm just looking at the question by Ladmila, if the data the evidence are not of great power, then certainly we would encourage the generation of additional evidence through varied settings across the world. And often that will be listed as a research priority in our guidelines. And certainly, if a recommendation is conditional, but we can collect more data, we can reassess those data, and it could even become a strong recommendation in the future. So I think, firstly, a recommendation is a recommendation, whether it's strong or conditional. But if it is conditional, certainly additional data can support having a stronger recommendation.
Thank you so much, Carrie. So I believe that's it for now in the chat. I see. So Dr. Sidaporm is first, then Dr. Anurag, and then Dani Badila. So please, Dr. Sidaporm, please. Or you already lower your hand. Dr. Sidaporm, would you like to? Okay, so while we are waiting, Dr. Anurag, please.
Okay, quick question. Congratulations, Kerry and the WHO team for updating the undernutrition guideline as well as bringing out these important documents on social protection. Systematic reviews have shown that undernutrition is almost affecting half of people with TB worldwide, and a significant proportion have severe undernutrition. But at the moment, we lack really situation analysis of how many programs are really into the pathway of nutritional assessment, counseling, and nutritional support. And would you be now considering linking these new documents to indicators which will be presented in the annual TB reports? For example, numbers. Yeah. So those two quick questions. Thank you.
Yeah, thank you, Anurag, for the question. As I mentioned it very briefly, but we are in the process of producing an operational handbook, and those operational handbooks usually complement the WHO guidelines and provide information to countries and programs on how to operationalize the WHO recommendations. We will have a discussion on perhaps higher level programmatic indicators, but that will take place as part of that discussion around the operational handbook.
Thank you so much, Carrie. And we also have a question from Dani Badila, please. Dani, sorry, we need to switch one second. So do you hear the translation, dear colleagues? Okay, Dani, please.
I don't hear Dani now.
Because
Amelia,
I can't hear anything in English. Colleagues, do you hear Dani in English?
Hello. Good morning. Hello.
Yes,
Do you hear?
yes, Dani, we can hear you. Dani? Dear colleagues, do we have translation? Because we do not hear anything in English.
Yeah, you need to select interpretation in English. We are here. Interpreters are here.
Yeah. Hello.
We are in English. Dani, can you choose the French
translation?
I was saying that
you, the listeners, should speak English. I think we are interpreting Dani.
Yeah, but we are in English channel and we do not hear the translation. Okay.
We are the interpreter.
Okay.
Yulia, I think that's Dani speaking.
Can you hear us? Yes, we are speaking. The interpreters are in English.
Yes, we know that you are in English. I'm in English as well, and we can't hear translation.
We are interpreting. You need to select English.
Dear interpreters, we are in the English channel.
Please translate the questions from Dani.
Yes, can you translate it right now? We can hear you, the translators. Can you Or Danny, would you?
Danny, est-ce que c'est possible pour parler en français, mais c'est nécessaire pour changer le bouton d'interprétation en français, s'il vous plaît?
Great, Monica, thank you.
Oui, c'est vous. Changez, s'il vous plaît, en français. If French translators can translate, I'd appreciate, because my French is not very good. Please. Oui, ça va, mais est-ce que c'est possible pour changer
Possible for you to change
le
Now we
bouton
can hear you.
en français, s'il vous plaît,
Can you
Danny?
change your original language to French, Danny?
Danny, or would it
So,
be? Okay.
yes.
Ça marche.
Ça
Allez-y.
marche.
All right. Thank you so much. So I was saying thanks for the floor. And I was saying thanks for the floor. And Dani Badila, and I'm from Help for Prisoners organization. And we work in DRC, in the prisons of DRC. And I would like to thank the presenters for the topic, this important topic, and mainly what is happening in our prisons. There are different data that converge with the work and the different survey that we did in DRC. So what is important for me is mainly the support with vitamin D. So I would like to know, beyond vitamin D, are there no other nutrients that are identified for prisoners? Because some of the prisoners do not also benefit from time to be under the sun. They spend all their time in the cells. So is there any particular results for prisoners who suffer from TB and who remain under shadow for a long time? So in addition to TB, are there no other thing missing? And I do agree with the multisectoral approach, where we need to consult all these sectors that could really work for social protection to make sure that we are supporting TB patients to follow or observe the treatment, because this is a big challenge for our country and maybe for. So I would like to know if, particularly I want to know if in addition to vitamin D, did you identify any other thing? And also, how can we put in place a program of support in this sense? Thank you.
Carrie, I hope you managed to capture the question.
I think so, Yulia. Yeah, and if I haven't, please someone can add. But just to say that vitamin D, there is a recommendation for vitamin D, but it is only in the context of research, because there were only 2 studies. They had different definitions of vitamin D deficiency, different doses of vitamin D were used. So the guideline development group at the time did not feel comfortable recommending this. There was insufficient evidence, and the evidence that we did have was not standardized. So I think it just needs to be clear that that is only for research. And for other micronutrients, we didn't have any suggestion that other micronutrients would support TB treatment outcomes. What is important, I think, is the actual nutritional intervention. So let's call it macronutrient supplementation, and certainly being able to provide that for people in prisons who have mild, moderate, or severe undernutrition. And we were very fortunate, actually. Danny was at our stakeholder consultation last week on TB in prisons, and there were some good examples there, I think, of providing nutritional support to people in prisons, including through prison gardens. So I think we can link Danny up with some of those presentations if he hasn't received them already. But certainly, I think people in prisons who have undernutrition, usually defined by doing their BMI, would need to be provided with additional nutritional support. And there are some non-governmental organisations who are supporting that. And I think that's the sector that Danny's coming from. So it's great to hear from Danny again, and we can link him up with some of those other programs. Thank you.
Thank you so much, dear Carrie. I see another hand. We are a bit over time, but I believe that we can have the last question and continue our discussion in the chat. So,
Yeah.
Ludmila Lucia, please. Ludmila Lucia, we see that your hand is on. Okay, I believe, colleagues, if you have additional question to Carrie, we can continue the discussion in the chat. So please keep the discussion forward. Yeah, while Carrie is with us, I believe till the end of the webinar.
Yeah.
We will have
Definitely.
another window for Q&A, and you will be able to to ask the question. So thank you so much for your question and your comments. And before we proceed, may I invite those who are able to switch on your cameras so we can take a group photo as a memorable piece of this webinar, and we will take 2 quick screenshots. So dear colleagues, can you not highlighting me, but all the group? Vlada, can you switch off highlighting? And we will take a quick screenshot. If you prefer not to appear in camera, feel free to drop a greeting in the chat as you did already with your country and organization. But those who are available to switch on your camera, we would be happy to have you. Thank you so much. It's so great to see so many beautiful people. Thank you so much. Dear colleagues, please indicate when you're done with the photos. So we captured everyone. We had the biggest number, so 202 people today. So there are a lot of pages that we need to make a screen. So please keep smiling. Alia, can you indicate us when you are done with photos, please? Done? Okay, thank you so much. But people, if colleagues, you're comfortable keeping your camera switch on, please continue. It's great to see all of you. So as is our tradition, we will share all the photos and the recording and follow-up materials from today's webinar on the WHO and TB Europe Coalition channels. And now let's turn to our special panel, where we will hear practical experience and insights on joining forces across sectors and advance action on the drivers and determinants of TB epidemics. A quick technical note, our team will post instruction in the chat on how to use slides in different languages one more time. As a reminder, you can choose the screen with your preferred language in English, French, and Russia for those who joined recently as well. So a kind request to our speakers, please keep an eye on the screen timer, aim for 15 minutes, and maintain a measured pace so that our interpreters can provide high quality simultaneous interpretation. Dear colleagues, can you please switch on the presentations so that, yeah, thank you so much. And with that, it's a great pleasure to invite Dr. Anurag Bhargava, Professor, Department of Medicines, Kasturba Medical College, Mangalore, Manipal Academy of Higher Education, Manipal, and Adjunct Professor, Medicine, McGill University, Montreal, Canada. Dr. Bhargava, please, will speak about integrating nutrition and food security into TB response. So please, the floor is yours.
Thank you so much, Julia, and the WHO team for giving me this opportunity to interact with such a diverse and distinguished audience from across the globe. And my presentation, I'll try to keep to the time, will be about integrating nutrition and food security into the TB response. And let me say this, that still in India and many other LMICs, the most prevalent problems of public health are related to nutrition, of which TB is one of the effects. And if we address nutrition in general, we will see a response in both the morbidity and mortality in the TB epidemic. Next slide, please. So everybody on this planet should be able to afford and access a healthy diet. Is there a problem? Am I audible?
No. Yes, continue, please.
Okay, there was some. So, but as you can see, these are two snapshots from the percentage of people unable to afford a healthy diet. This is from South Asia, and then you have a snapshot of the situation in Europe. So, across the globe, actually, the situation is either grim or a serious. It's a matter of concern still for countries in Europe. And when we talk of TB, we are talking about the lower socioeconomic status people. And for them, this is even a greater challenge. And you can imagine if somebody falls sick with TB, what the situation will be. Next slide, please. So we in public health and clinical medicine talk about communicable diseases and non-communicable diseases. But I would like to highlight the fact that, undernutrition falls in the no man land between these two conditions and actually is related to both of them. So it is Janus faced. And we know from the 1950s onwards, when the WHO published a monograph, that undernutrition can compromise the immune system and lead to more frequent and more severe infections. So there are a lot of diseases which are communicable, which are nutritionally sensitive. And this includes TB, but a host of other diseases. And every year, almost 5 million children die of, under the age of 5, and 45% of these deaths are related to common infections of childhood made more severe due to undernutrition. On the other hand, we also know now that people living in food insecurity cannot access a healthy diet, so they just have processed food with high sugar, fat content, and maybe with a sedentary lifestyle added, and this gives rise to diet-related NCDs. Including obesity and then its effects, including some types of cancer. Also, there is, a direct relation between undernutrition in early life, in intrauterine and in the early years, and higher risk of obesity, diabetes in later life. So these are actually interlinked epidemics, and a transformation would happen if we were able to address food insecurity apart from, access to healthcare. Next, please. So specifically coming to TB, actually we know that the two, undernutrition is both a contributory cause and a consequence of tuberculosis. And so I'm proposing there are two propositions here. Infection is necessary for the development of TB, but not sufficient, because we know that even with infection, most of the people escaped development of tuberculosis because of the functioning of the immune system. And anything which compromises the functioning of the immune system would be a risk factor for TB. And of the leading risk factors, as highlighted by Kerry, undernutrition is the commonest cause of immunodeficiency globally. When we talk of poor treatment outcomes, and we are still losing a lot of people every day to TB, about 3,400 deaths occur every day due to TB. So treatment of patients with drug alone is necessary, but not sufficient to reduce mortality, because people do not die of TB in general, but because of severe disease or severe comorbid conditions. So here again, undernutrition is a contributory factor for TB mortality and multiple other adverse outcomes, including drug toxicity, recurrence, etc. So if we are talking of reducing TB incidence, we need to address the risk factors. And if we want to reduce TB mortality, we'll have to address these comorbid conditions in addition to providing effective anti-TB therapy. Next, please. So I have worked extensively in rural India, and I was actually, we published the first cohort study of what is the nutritional status of TB patients in India. And that showed a very grim situation, which is reflected both in this box plot and the photographs, which are very disturbing. And you can see that patients had a very, most of them were seriously underweight, with median weights of 34 in women, and these are adult women, and 42 in men. and the BMIs were going below 10, even below 10. So at those levels of BMI, undernutrition is directly contributing to mortality. And our kind of data was corroborated by the data from the national program, which showed that across India, weights in TB patients were very low in adults also. If you see this photograph, you can see most of these people are young and clearly in need of nutritional support apart from TB therapy. This is a family of, a portrait of TB where one was cured and he brought two other people again underweight in the family with TB. So next, please. We also showed that this states of undernutrition were associated with 2 to 4 fold higher risk of mortality. So I don't want to, underscore this, but Peter Pyatt has said that, this remains an essential need which has still been unmet for patients with TB or patients with HIV. And in that sense, this is an urgent as well as an important situation. Next, please. Thankfully, actually, the government responded to our cohort study data. And since 2017, we have a guidance document, which was an adaptation of the WHO guidelines. And following this guidance document, the government announced a direct benefit transfer of 500 rupees a month for every patient with TB, which has now been doubled. And although this is a modest figure, a study has shown that unfavorable outcomes were associated with non-receipt of this direct benefit transfer. So almost 5-fold higher prevalence of unfavorable outcomes. Now, there is also a food basket scheme, which is driven by voluntary donors, introduced in 2022. Next, please. So our rations trial, which I'll just talk about briefly, which is sort of also informed the WHO guideline. So there are some experiences and evidence that is worth sharing. So the two key questions were that, can a nutritional intervention reduce TB incidence significantly in a high-risk population? And these were household contacts of people with TB. And can a nutritional intervention improve TB treatment outcomes? Next. So this was a cluster randomized field trial conducted in 28 TB units in the national program in 4 districts of Jharkhand in eastern India. And the state has a high proportion of population of indigenous communities. So in this trial, we had a trial population of household contacts who were enrolled and followed up for 2 years, in a control arm where the household contacts were on the usual diet, and in the intervention arm where they received a combination of food baskets and micronutrient supplements. All patients, because for ethical reasons, were provided food baskets in the trial. There were 2,800 of them. Next, please. This trial was conducted between 2019 and 2022. And our intervention was very simple based on the guidance document referred to earlier. Every patient received a 10 kg food basket in addition to whatever direct benefit transfer they were receiving. And this ensured that they had access to good quality protein in the form of a powder of, a Bengal gram and milk powder and oil, providing about 1,200 extra calories and 50 grams proteins per day. And in the intervention arm, every individual family member for a period of 6 months received additional rice and additional pulses in addition to multivitamins. In the control arm, the family members were given nutritional assessment and dietary advice, and they had access to all the programs of the government. The cost was actually quite modest, and if you take the total family, it was about €1 a day to cover the entire family with 1 patient and 4 contacts. Next, please. So just this slide is important because we often don't know what is the severity of undernutrition in our patients. And in our cohort in 2019 to 22, nearly half was severely underweight, and 1 in every 6 patients had a BMI less than 14. So clearly they were in need of nutritional therapy, not just nutritional support, but nutritional therapy. And we had almost 10% of patients who were seriously ill. And these are still not being picked up in programs, across the globe because we are not really assessing them for this. And only 3% of patients were able to do their normal work at baseline. Next, please. In the household contacts, the most, the highlight was the prevalence of undernutrition across age groups. And you can see, according to the WHO standards, the situation in children was critical, and in adults and adolescents, it was between 20 and 39%, indicating a serious situation. So household contacts also had high prevalence of undernutrition, again requiring this intervention. Next, please. So the outcomes, Kerry has pointed out to one outcome of 39% relative reduction in TB incidence in the intervention arm because of this intervention, and this was adjusted for various confounding factors. And in a sensitivity analysis with Cox proportional hazard, again, actually the results were consistent. When we talk of only lung TB cases in the household contacts, the protection was 48% relative reduction in incidence. So it was an even stronger effect for lung TB. Next. And in the patients who were severely underweight and often seriously ill, the treatment success was 94%. With a median weight gain, which was about 1.5 times what has been recorded in the national program. And most encouragingly, 75% reported that they were able to return to normal work at the end of treatment. So there was functional recovery also apart from nutritional recovery. The death rate, even the severely undernourished and severely ill cohort, was less than 4%. And again, there was high level of treatment adherence. No patient with MDR-TB died during this thing, although the numbers were relatively few. Next, please. So one thing about TB deaths which we noticed, which is worth sharing, is that we assume that patients would really put on weight with effective treatment. But in a poor household with food insecurity, this does not happen. And a study has shown that 60% had static or decreasing BMIs, and this was increasing the risk of death in the first 2 months by 5-fold. On the other hand, in our trial, we found that when they gained about 5% of weight over their baseline weight, this reduced the hazard of death by 60%. And we had extremely low BMI patients who also survived. Again, this was not a trial, but when compared to other trials where there was no food support, we saw a very encouraging reduction in TB mortality as a result of the intervention. Next, please. So when we are talking of TB control, it requires a combination of biomedical interventions like our therapies, but with social interventions. And nutrition has to be an integral part of both the public health approach to TB control and the clinical approach in our patients. So nutrition supplementation is a potential public health intervention which is TB sensitive, and it can help be a complementary strategy in communities with the burden of TB and undernutrition. And in patients with TB of the kind that we see in India, along with effective TB treatment, nutrition support is an essential, not an optional component of person-centered care. And it can improve outcomes. Next, please. So a modeling study by Finn McCade and colleagues have shown, based on the Rations trial evidence, that even with a 50% coverage of households, the number needed to treat to prevent a TB case or prevent a TB death are very encouraging. Next, please. So this is just a picture from the field trial, and an 18-year-old with a BMI of 10.7 was unable to walk, then starts walking with a stick, and then finally gains about 16 kgs and returns to cycling and doing his normal work. So this is really the most encouraging part, the transformation that we saw in patients in the trial. Next, please. So I would say the way forward is, and I take this from the Thai colleagues who said that the triangle that moves the mountain has to involve the political involvement, the knowledge creators, and the social involvement. And clearly, if you're talking of integrating nutrition into the TB response, we need facilitation by other measures from the governments, including health coverage, health and all policies, involvement of other sectors that we're going to talk about. As a whole, the healthcare sector has to be more attuned to assessing nutritional status and addressing it, because still that is a blind spot in healthcare. And civil society can function as advocates and watchdogs and build coalitions and mobilize people through the social movement and mass media. Next. So this is my last slide. In fact, So in 1974, the director of nutrition in WHO, Dr. Moises Bihar, said that at that time, the most effective vaccine for diarrhea, respiratory infections in children would be an adequate and balanced diet. So broadening that metaphor of a vaccine being anything which can protect one from disease, this is a essay that I've written for the PLOS Global Public Health. Just positioning adequate balanced food as a vaccine for TB and other diseases. So not only does it work in terms of prevention of TB deaths, but also for prevention of recurrence. It can be, it has all the qualities of an ideal vaccine: oral, polyvalent, safe, can be grown very easily and dispensed over the counters, and will be taken with a high compliance. And of course, it can, help potentiate the effects of other vaccines, etc. Thank you so much for your attention, and it's my pleasure to acknowledge the support we have had from the Indian Council of Medical Research, the Central TB Division, and my colleagues in our departments, Dr. Dick Menzies, Dr. Soumya Swaminathan, and of course the communities which really made it all possible and worthwhile. Thank you.
Dear Anurag, sincere thanks for your presentation and the rich information you shared. You just powerfully highlighted the importance of addressing nutrition and food security within a comprehensive TB response. And until a new TB vaccine is available, adequate quality nutrition remains one of the most effective forms of prevention. So, dear participants, a quick reminder, you're welcome to post questions to Anurag and to Kerry in the chat at any time, and we will take them during the discussion immediately after this panel. Dr. Anurag, there is one question already addressed to you, and Kerry, there is also addressed a question to you in the chat. Dear colleagues, please switch off the slide sharing right now. And moving on, we turn to leveraging the social development and labor sector to deliver social protection for people with TB. It is my great pleasure to invite Dr. Tom Wingfield, a consultant physician in infectious diseases, co-founder and deputy director of the Center for Tuberculosis Research, a reader in tuberculosis and social medicine, Liverpool School of Tropical Medicine in UK. Tom, please, the floor is yours. Dear colleagues, just a small note. We do not have the translation for French and Russian, so we have only English presentation here, but our translators will help us to understand the meaning of the presentation. Thank you.
Thank you, Yulia. Thank you, Monica, and all colleagues as well. Lovely to be here. Can you see my slides?
Yes, yes, yes.
Great, thank you. And you've already given the introduction. So we all know that the free TB care is a fallacy. And this is a quote from a focus group discussion from a person with TB in Nepal who said, "It takes 3 hours to reach health facilities by walking. When I can't work, I don't have money. When I don't have money, I can't ride the auto to reach the clinic because it costs 300 rupees. I can't earn 3 penny. How can I pay 300 rupees?" That highlights the importance of social protection that we're here to talk today to fill this gap. What is social protection? It's a human right. It is programs that are designed to reduce and prevent poverty and vulnerability, be they from left to right cash or in-kind cash transfers, food and food security, as Prof. Bhargava was talking about, insurance and welfare, or universal health coverage. And these are to provide support across people's lives, so from maternity, families with children, to old age, and also the death of breadwinners in households. But also at times of crisis, and I think that's probably the most important for this talk on labour and social development, sickness, job loss and disability, all of which we know and will come to affect people with TB greatly. Where are we with social protection coverage globally? Well, although it's increasing, still only half the global population is covered, which leaves 4 billion people worldwide not covered by any form of social protection. And when you look at the situation in lower middle income and lower income countries, that is far worse, with in low income countries less than 1 in 10 people covered with social protection. And we know that's also the case for underserved groups within those countries, particularly for people with tuberculosis. But what's that all got to do with tuberculosis? Well, we know when we look historically at data, in this case from Europe, London, Stockholm and Hamburg, on TB deaths on the left-hand side there, that TB deaths were increasing from the year 1750 on the bottom left to 1950 on the bottom right in Europe. And they were decreasing dramatically despite being before the discovery of Mycobacterium tuberculosis in 1880, the discovery of streptomycin in the 1940s, which heralded in the antibiotic era, and the use of isoniazid as a TB preventive therapy. And the key reasons for that were improvement in living and working circumstances, including poor laws, the passing of relevant legislation, better nutrition, lower crowding, and better hygiene. And the same can be said today, as been shown, but I think it's important to show again, we know that undernutrition, which is driven by poverty, is a key attributable risk factor for tuberculosis. But if we look at some of those other risk factors, alcohol use, smoking, HIV, diabetes, we know that there is a strong link between socioeconomic status or poverty level with all of the factors that drive tuberculosis. And it's not only that drives tuberculosis, but having TB, illness and care seeking compounds poverty. And as Kerry has shown earlier today, 1 in 2 TB-affected households incur catastrophic costs. If you're in a drug-resistant tuberculosis household, that's 4 in 5 drug-resistant TB-affected households incur catastrophic costs. When we look a bit more deeply at why people are incurring those catastrophic costs and what are the costs that make this up, you'll see from all the cost surveys here done there in many different countries, over 25 countries by WHO, that actually the direct medical costs, such as pills and tests, make up a small proportion in the dark blue on the left-hand side of the total costs. And other costs, such as direct non-medical in the lighter blue in the middle, such as food, travel, accommodation associated with getting a diagnosis, having directly observed therapy, make up a larger proportion. But then on the right-hand side, vital for this discussion and this presentation today are the indirect costs. And this is income loss and productivity loss in the orange bars on the right-hand side. And you can see that overall, nearly half of the costs are made up by such income loss. And in some countries, if you just pick out there, Burkina Faso, Mongolia, Brazil, actually the income loss is the main driver of these catastrophic costs. And that's why income loss and indeed support for income is so vital for people and households affected by tuberculosis. We know why this happens when we work on the ground, either in hospitals where I work or in research or in policy, that the levels of unemployment during TB illness go up markedly. And here again, this is from those surveys showing in the red bars during a TB episode, the level of unemployment, and in the blue bars before TB episodes. And you can see that in some cases, actually there's 5 times the level of unemployment during TB episodes compared to the same individuals prior to their TB. So unemployment levels are rife and lead to a decimation of income and earning opportunities for people with TB and their households. We've known this for over a century. Robert Koch there on the left-hand side, who discovered the TB bacillus, said that one of the most powerful weapons we can use against TB is social welfare centres, so support for people socially, including work and food. And fast forward nearly 100 years, Professor Chakaya Mua, who ran the TB Union, called for coordinated multisectoral action to address social determinants of TB by 2030 and said, we've done this before in high-income countries. Would it be too much to ask for partners to target social drivers to end TB in low and middle-income countries too? Generally, how can we reach people with social protection? And Kerry alluded to this earlier in her presentation. There's 2 main modes. The top one there on the left is TB-specific social protection. So this is where you provide social protection if people have TB to them and their households. So you have to have TB to get this support. And an example of that on the right includes monthly food vouchers or vouchers to support treatment, as has happened in South Africa and other places. But Complementary to that, and perhaps even more important, is TB-sensitive social protection. So this is where social protection is not limited to households and individuals affected by TB, but they can be included in the eligibility criteria for this social protection. So these are people perhaps who are living in poverty, living with undernutrition, who are at risk of TB, or have been affected by the consequences of TB in the past. And an example on the right would be the Bolsa Familia cash transfer program in Brazil, which has been shown to both prevent TB and to improve TB outcomes in those affected. So how are we doing in terms of social protection implementation? Well, just under 2/3 of people with TB get some form of social protection. But we have to acknowledge that the main form is enabling healthcare-oriented support to make sure people get through treatment. Very important, but it does need to acknowledge that actually other supports such as food or food security, as the rations trial and Prof. Bhagava has shown, and compensating income loss or cash transfers make up a far lower proportion, reach a far lower proportion of people with tuberculosis. The other hidden figure in that is that mostly these support mechanisms are restricted to people with drug-resistant TB and not other equally vulnerable people who have drug-sensitive TB. And finally, when we think about the burden of TB in lower and middle income countries, actually, we know that about 70% of the workforce in low and middle income countries are employed in the informal work sector. And so this compensation of income loss is not something they're going to receive from other sources. And so it becomes even more vital to be accessed. What's the proof that we have that social protection works? Well, social protection is a holistic public health intervention. We worked in shantytown communities of Peru around Lima in the household randomized evaluation of social and economic support called the HRESIP study, providing cash transfers, which were conditional for people with TB for taking their treatment for over a 6-month period, given monthly, and also to their household members for coming forward for TB screening and preventive therapy. Cash transfers were also provided for attending TB clubs that you can see there on the bottom picture, which were mutual support groups which were there to inform and educate about TB, but also to reduce stigma and empower people with TB in their households. We found that in the households that received those interventions versus the control households in grey, the intervention households in dark, there was a reduction of about 1/3 of catastrophic costs in the intervention households. We weren't able to completely mitigate them, but we were able to reduce them. We scaled up that intervention into the community randomized study to show that social protection is also prevention in this study led by Professor Carlton Evans and Simona Datta of the Innovation for Health and Development team. So we provided the same intervention, but in 16 communities, the people with TB in their households received this, and in 16 communities, they did not. And it was found that in household contacts of people with tuberculosis, that from this social and economic support, there was a reduction in those household contacts who developed TB disease by 43%. So actually very similar to what Prof. Anurag has showed you from nutritional support. But social protection is also person-centered care. So the same intervention was shown to reduce adverse TB treatment outcomes in people with TB in households that received this socioeconomic support by 35%, so a reduction in abandonment of treatment, loss to follow-up, treatment failure, or death. Again, not through medicines or tests, but through social and economic support. And the evidence goes way beyond Peru and way beyond the cash transfer and socioeconomic support intervention I showed you. And with Molly Hudson and Priya Shetty, we've done a systematic review and meta-analysis of social protection using a broader World Bank definition, which includes other things, including vocational training, including nutrition, including insurance, which has shown that overall social protection doubles the likelihood of TB treatment success in those who receive it. And as Kerry has shown in the first presentation, we do have the policy now and guidance on social protection for people affected by TB from WHO, including the implementation aspects of that. And we have the pledge from our 2023 meeting that 100% of people with tuberculosis have access to a health and social benefits package by 2027. We also have the framework for delivery, which is where this whole meeting comes into play with the Multisectoral Accountability Framework. And the reason that that's important is that it embeds engagement not only in the health sector, but also labour and social development sectors within national accountability. And we know that actually just under 2/3 of countries already have high-level accountability review mechanisms in place from which to build. And just to highlight some of the areas that we could build on, the commitments we already know, not only the high-level meeting on TB, but the universal health coverage, and also the Sustainable Development Goals, which are monitored in real time. The actions can go beyond the health sector and also beyond policy and practice and move into more legislation, both in the workplace and also in communities that's both person-centred and human rights-based, and promotion of some of the findings and pledges from the UN high-level meetings, especially on universal healthcare and addressing these social determinants of TB. All of which, as Anurag has alluded to, must be underpinned by community and civil society organisation support and be locally appropriate and needed by the communities that we serve. We now have a way we can monitor social determinants and health risk factors, including through national TB patient cost surveys, social protection mapping, as in the policy before, so that we can monitor and report on the progress that we're making towards these activities. In terms of the ministries, we often focus on the health ministries, but as was in Peru, there are other ministries that need to be involved, whether that be labour or employment, or social protection, inclusion or welfare, and key also housing and the environment. And working across these ministries and exploring what linkages already exist is crucial. So we're already working to look at social protection in other countries and adapt that from the Peruvian setting with Dr. Kritika Dixit and Bola Rai there of Birat Nepal Medical Trust in the ASCOT pilot trial of socioeconomic support in Nepal, and with Ahmed Fouadi and Fini Fitriani of Universitas Indonesia in the TB CAP study in Indonesia. So there is a way to consider and monitor, evaluate how we can implement these and how successful they are in other settings. And if any of you are interested in learning more about this or joining a network of people who are passionate and committed to social protection and tuberculosis, please do have a look for the Sparks network and the Shift TB network, which is a social science network. So in conclusion, we know that poverty drives TB, but having TB illness and seeking care makes poverty worse. We can see from the breakdown of catastrophic costs that lost income and unemployment are key contributors to these catastrophic costs. And we know that pills and tests alone will not be enough to end TB. We need to combine both health and social protection benefits in order to end TB. And to do that, we'll have to work across sectors and across ministries. And both action across those ministries and sectors and accountability will be vital. Thank you for listening.
Dear Tom, thank you for such an insightful analysis. And it is hard to overstate the role of the social development and social protection system along with the labor sector in supporting people affected by TB. And your presentation made it clear when income, security, decent work, and social support are aligned with health services, multisectoral action become real. Thank you again, being on time, even earlier. So, dear colleagues, once again, a quick reminder, you're welcome to post questions in the chat at any time, and we will take them during the interactive discussion right after this panel. So now I'm asking my colleagues to switch on slides for next presenter. And now it is my pleasure to invite our speaker from Azerbaijan, Ms. Fakhriya Husseinova, Monitoring and Evaluation Specialist, Main Medical Department of the Ministry of Justice. Ms. Husseinova will outline how the justice sector partners with health and civil society to prevent and manage TB in prison, an approach widely recognized in the region for its innovation and results. So just a brief technical note. Ms. Husseinova will speak in Russian, and if you require interpretation, please select your preferred language channel using the globe icon on the toolbar and kindly switch off the original audio. So, Ms. Husseinova, the floor is yours.
Hello, dear friends. Thank you very much for introduction. And I would like to present our experience of prevention and treatment of TB among prisons, and will tell you how different sectors help us in the implementation of TB strategy in our country. The main medical department is a structure within the Ministry of Justice, which was created in 2005. And this structure ensures the entire spectrum of services to prisoners and officers. And the goal was to ensure organizational, financial, and personnel issues efficiently, especially when we talk about such sensitive issues as infectious diseases, including TB. Since the very beginning, we built our work on the principles of openness and partnership in close collaboration with the civil sector, which is a key element of success, which we see today. Every year, up to 200 prisoners are referred to civil healthcare centers for computer tomography, MRT, cardiological studies, and other medical services. Since the moment when the country shifted to compulsory medical insurance, we see the coordination between the Ministry of Health and other partners. And the goal was to ensure continuity of care for prisoners during their stay at penitentiary facilities. At the penitentiary system, we have a standard system for registration and treatment of TB, which is integrated in the national platform TB Manager. It helps us to work synchronously with the national TB program. Since May 2021, all laboratory studies of civil medical sector, including bacteria culture, are done on the basis of specialized treatment institution at the Ministry of Justice. And now we have the problem with the National Reference Laboratory, which is being under repairs now. But to ensure the continuity of treatment and laboratory studies, all these medical examinations are done at the Ministry of Justice facility. The doctors' teams and medical teams include the representatives of both penitentiary and civil sector, which ensures the unified approaches and standards. Next slide, please. Our main goal is to ensure the continuity of treatment of patients with TB before and after discharge from prisons. We understand that TB is not just a medical, but also a social issue. That's why we need to imply a comprehensive approach. Medical support, social adaptation, and collaboration between all stakeholders is important. So we created the legal basis. Two key documents were signed: memorandum on understanding between the Ministry of Justice, Ministry of Health, and International Red Cross Committee, and memorandum on collaboration between the main medical department and the non-governmental organization. These agreements ensure the legal support to our activities. They support the referral of our patients after they discharge from prisons. All this approach is also reflected in the national TB-related documents. Next slide, please. Preparation of patients to discharge from prison, to release from prison, starts several months before. So the educational sessions are organized for prisoners. We explain the need and continuity of treatment. Also, non-governmental organizations which are involved in this project collect information about the social conditions, about relatives, habits, educational level, and professions of prisoners who are being prepared to the release. All this information is collected, and this data help to correctly organize the follow-up of these former prisoners after they are released. Medical documentation is sent to the national TB programs and to TB clinics at the place of residence of the patients. Medicines that are purchased at the expense of the Global Fund are sent to the points of care. So that is why there is no lag, no break between the prison health system and civil health system. After the release, our work continues with the patients, and we help patients to be registered. This is done by the non-governmental organizations. They provide medicines and food ratios every month, and if possible, some material assistance to patients. We conduct a monthly monitoring and collect data for laboratory analysis at the Ministry of Justice. Psychologists and social workers visit patients at home, help them to resolve legal issues, and this makes the process of reintegration safe and humane, and reduces the risk of treatment interruptions. Within this project, the non-governmental organization, which helps us since the beginning of next year, plans to monitor treatment of former prisoners who were receiving treatment for hepatitis C in prisons. So the monitoring will continue by this non-governmental organization. In 2011 until 2024, 944 patients with TB were released from prisons. Among them, 390 with resistant TB, drug-resistant TB. They received social assistance, help in employment, with housing, and these activities were conducted by the NGO, which helped us in these activities. Also, in 2011, we introduced One Impact application in Azerbaijan with the help of Stop TB Partnership. This application helps to provide assistance to patients online, and the results exceeded. Treatment interruptions reduced from 92 to 3%, thanks to the activities of the non-governmental organizations and thanks to the continuing treatment of these patients. It is an example of how the civil society organizations and social support can change the situation. Thanks to these efforts, the penitentiary sector achieved the sustainable reduction of morbidity and mortality. And you see this on these diagrams for the recent years, 2005 to 2024, decreased by 5 and 7 times. Efficiency of treatment will be described on the next slide. So efficiency of treatment in the penitentiary system is 96% among patients with drug-resistant TB, and 85% among patients with rifampicin-resistant TB. And this shows that penitentiary sector of Azerbaijan exceeded the international standards of treatment efficiency. Next slide. All these achievements are the result of the systemic activities within the national TB program, and we are sure that only collaborative efforts of all sectors, healthcare, justice, civil society, may help to achieve the success. Summing up, I would like to underscore that TB activities in prisons is just a part of our strive to just society when nobody is left behind, even after serving the term in prisons. And it is the road to sustainable results, which we are having now. Thank you for attention, and I hope that our experience will inspire you, and I'm ready to answer your questions if you have them. Thank you.
Dear Ms. Husseinova, our sincere thanks for sharing Azerbaijan experience. It is a clear, practical example of how sectors can work together, including with the meaningful engagement of civil society to strengthen TB response. And for our final intervention today, we will keep the practical lens and turn to the role of civil society and community organization in national TB response. And our next speaker will illustrate how partnership with communities make multisectoral collaboration concrete, particularly with the social protection, labor, nutrition, and justice sector. So it is my pleasure to introduce Ms. Idalia Savadogo, WHO Civil Society Task Force member and Program Officer, Technical Assistance at the Access to Essential Medicines Network, Burkina Faso. So once again, a brief technical note, Ida will be speaking in French, and if you require interpretation, please select your preferred language channel using the globe icon on the toolbar and kindly switch off the original audio. So, dear Ida, the floor is yours.
All right, thank you so much, Julia. As you said, a member of the task force of civil society of WHO for the elimination of TB. I'm doing this presentation on behalf of all the members of the task force, and I'm also the coordinator of TB, Women for Francophone Africa, member of the delegations of the community at the board Global Fund level. So I will be speaking about how to reinforce collaboration between CSOs in the implementations of MAF-TB to actually address TB and ensure that nobody is left behind. Slide, please. So we will quickly present the situation we've already heard and follow the different presentation, and we can understand that TB is a public health issue in the world. And in 2023, according to data, we have 10.8 billion of people contracted TB in the world, and this led to the death of 1.25 million people. So this make TB a disease that is the deadliest disease after COVID-19. And we also know that TB remains the deadliest and is also the cause of the death related to antimicrobial resistance, and also the leading cause of the death of people living with HIV. And in addition to that, we see that in many countries, there's what is in place, a national program for the fight against tuberculosis. And those programs help us have like an impact in our effort to eliminate TB. Slide. So how can we establish a partnership with civil society organization in collaboration with other sectors for the fight against tuberculosis. Here we talk about different domains to consider. We have, for example, intersectoral partnership that cover health, social sector, and also education sector. And we've seen with the colleagues who presented how it is possible to bring all these sectors in a collaborated effort to eliminate TB. A domain in which we need to act is community engagement. And by community engagement here, we think it can't be done through advocacy, through community and civil participation, and also through community meetings that can be organized at the local level. And we know that currently communication is very important and has like a key role in the fight against TB. In TB community, we need to act on health literacy and also work on awareness raising. And another field important in which we need to focus on is local capacity building for research and also monitoring. Slide. So I will go deeper on all those sectors. For community mobilization and also community participation, we know that communities are at the foundation of all effort to eliminate tuberculosis, because it is in communities that we have contact cases. It is also in communities that we can fight easily against TB. Because of that, we need to mobilize communities. We need to really give people affected by TB, we need to give them the knowledge and skills needed for their participation, active participation in research, not only research, but also active participation in research of cases, contact cases. And they also need to participate in advocacy, targeting communities and also leaders in communities and also decision makers. And that commitment can facilitate multi-sectoral engagement and also redivability. And we also have the fact that in our different community, we can organize community meetings. And those meetings can help deepen understanding of factors that influence screening and other aspects of the elimination of TB within the community. We can also, we also call our different decision makers and other intersectoral framework to support citizen and community participation, and that involve facilitating community participation in health processes. Slide. Now, when it comes to communication and health literacy, I can say that to ensure that nobody is left behind, we need to focus on communication, mainly raising community awareness on disease issues. And for this, we need to have awareness raising programs. Those programs could be program targeting people that are directly affected. And it will help inform them on the disease, inform them on screening, and also inform them on prevention practices. There is a need to improve health literacy. And what does this mean? It means strengthening community capacity so they can understand and be able to use the different health information to make informed decisions. And within our communities, we have associations of former patients of TB who can be voices that will contribute to capacity building within affected community, help them understand the disease. There's also the need for capacity building in advocacy. For this, we can give tools to communities. We need to provide them advocacy tools that can help them understand treatment and care policies that actually adapt to their needs. And there's also a need to engage communities in research and to make that, ensure that they are contributing in research on TB drug, and they will help actually guarantee that new treatments are relevant. Slide. And for this, we also need to have new tools. We need to implement the different tools that WHO slide in English, and need to have tools that can be used. And those tools can help address the issues of TB screening. How about monitoring and general monitoring? We need to reinforce local capacities by supporting community program with financing and monitoring mechanisms that are adapted and have like a global approach. And what does this mean? It means that we can put in place a global vision of proximity of health by addressing social factors and environmental factors that are influencing tuberculosis. Slide. And we will now talk about collaboration and the involvement in the fight against tuberculosis in other sectors. We've seen with the former presenters how the fight against TB can be done at the social protection level, can also how TB is influencing work. We have TB patients who lose their work because of their health status. And also in nutrition, we've seen that it has an important role in the fight against tuberculosis. It helps reduce the level of TB patient, the number of TB patients in the community. We've seen presentation on the need to fight against TB in prisons, and in all these sectors, we need to act for social protection. For example, I think CSOs can work in collaboration with the Ministry of Social Action. For the labor sector, we can work for the prevention and screening in health centers. And with the Ministry of Civil Service, Ministry of Labor, we can collaborate. For nutrition, there is a need to have like food support that can be done. We can work in collaboration with the Ministry of Health that will actually focus on the need to bring additional nutrients to TB patients to help them actually fight against TB. So with the Justice Ministry, we will be able to work for prison centers that are sensible to the need to actually prevent and fight against TB in prison. Slide. For social protection, with the collaboration of CSOs, we can work with Ministry of Social Action, and this will help reduce poverty. And we should also act for health insurance, and we know that there is a high burden of costs on the quality of life for TB patients. So it will be very important for these patients to have health insurance. We are talking about health. We are also talking about universal health coverage. In our countries, we need to really have health insurance practices to facilitate access to healthcare by TB patients. We also need social and financial support to TB patients. It will help them face the socio-economic impact of TB, and this will help reduce the loss of treatment observance. Slide. For labor, we also have the prevention of professional TB, which is important. We can do it through regular screening of workers, and we need to maintain TB patients' jobs. And we should also avoid stigmatizations and discrimination linked to TB at the workplace. Slide. For nutrition, we've seen how the availability of food support is important for the fight against TB. So we can have integrated program. We have organisms as PALM, global funds that are helping for access to nutrition program for TB patients, and mainly for children. And we also have food security, and social protection must be aligned to food safety. For example, give food stamp to the different patients to help them have like a good nutrition. This will reinforce their immunity system and also have a better response to treatments, right? So to talk about TB in penitentiary system, I think collaboration is possible with CSOs and communities, mainly collaboration with the Ministry of Health. In Burkina Faso, we call it Ministry of Justice. In other countries, we call it Ministry of Human Rights. So we can do collaboration through active and passive screening. Health authorities can implement systematic screening of prisoners. Once prisoners are admitted to the prison system, there should be a systematic screening, and also during their stay in prison. And there is a need to guarantee a continuity of treatment after they are free from prison, and this will help prevent interruption of treatment. And we need to also train prison staff, mainly penitentiary staff, so they can have knowledge on prevention, screening, and also how to actually take care of patient right to health. And we need to have a joint protocol, an agreement, a inter-ministerial agreement between Ministry of Justice and the Ministry of Health to define the responsibilities and procedures in terms of fight against TB in penitentiary system. To conclude, I can say that through this initiative, this MAF-TB initiative that allow the inclusion of other multisectoral actors for accountability, and also allow collaboration with communities and CSO. This will really help us reduce the number of patients, TB patients, and improve the conditions, living conditions of TB patients in our different countries. Thank you so much, Julia, and thanks for this opportunity.
Dear Ida, many thanks for your thoughtful and such a well-structured presentation. Meaningful engagement of communities and civil society organization across planning, service delivery, monitoring, and accountability is essential to progress towards ending TB. And your examples also showed how these actors help bring other sectors to the table and keep collaboration practical. So my warm thanks to all our speakers for the insights and experience you shared today. So dear colleagues, we can switch off the presentation mode. And now, colleagues, we would love to hear from you. You can highlight all the speakers. It's request to my colleagues. So now, colleagues, we would love to hear from you. What resonated most? What are you doing to operationalize MAF-TB and engage other sectors? What barriers are you facing, and which practices have worked for you? So please raise your hand to take the floor or share your points in the chat. Okay, so I see already 2 hands. Sorry if I will pronounce your name not really correctly. So the first one is Sekona Kalivongu. Please, you can switch on the microphone. I believe Sekona speak in French.
Presenters, my intervention will first be a comment on the presentation of she did a brilliant presentation that highlights the reality of in Africa. So I will just make a comment on Ida's presentation on 2 or 3 things. and mainly the nutrition aspect, which is a very essential problematic. It is very necessary that partners support patients in nutrition needs. And she also talked about protection. In Guinea, we specifically met two challenges, two cases where two patients were abandoned by, and even like abandoned by the family. Some patients also do not like going to health centers. So we have really challenges. Now the question is, what can we do as CSOs? And these are cases that we need to manage, and patient can support CSOs to take care of cases like that, help, for example, reinforce reflection on how to cover. So I would like to congratulate Ida because she covered detail. Yeah, very key. And I think it is important for us to take into account all the different aspects and now reflect on how to address them because they are really current problematic. Thank you, Ida, for this presentation. And we will really appreciate if you can share the presentation with us, and we'll really be pleased to have it. Now, for the first presentation, I have a clarification question, or I would like to also share some experiences. I think Ida also addressed it. It is a question of penitentiary system. In prison, whenever we admit people, we do screening, and when they are going out, we also do screening. Now, when they finish their stay in prisons and still have to continue with care, now I think there is a person who presented it. How can we ensure that we are still supporting patients when they are out of prison? How can we continue supporting them until they are fully recovered? I take an example. We have prisoners who come to prison from miles away, hundreds of miles away. And when they are freed, they will maybe travel 100 or 200 kilometers to their inhabitation place. So what are the experiences that you can share? Because 2 years ago, we really tried to integrate it in the strategic penitentiary plan. We had a lot of discussion and we're not able to cover how to ensure that that is maintained. So do you have experiences on how to cover the continuity of care for people who are 100 miles away from the prison? Thanks.
Thank you so much. I believe first, Ida, would you like to reflect on the comment? And then Kerry and I believe, Fakhriya, maybe you can also cover from the Azerbaijan experience, how Azerbaijan is supporting those people who are already leaving prison. So thank you so much. Ida, please.
All right. Thank you, Julia, and thanks, Sekuna, for your question. I think your intervention is much more about experience sharing. And there were also experiences shared from Azerbaijan. So after prison, there is a need to maintain contact. Mainly, communities have an important role in making sure that care is maintained after prison. So there's a need to have the contact, know where patients live, and be able to really monitor and ensure that medicines are still available to them wherever they go, and they are still having the needed care with all the support that come with, like social and nutrition support, and also be able to monitor their contacts to make sure that their families are also protected against TB. So this is what I can say on the question that was asked on how to monitor a patient after they are released from prison. Thanks.
Thank you so much, Ida. Kerry, would you like to?
Yeah, sure. No, thank you for the question, and a very important question. And actually, as I mentioned just last week, we held a stakeholder consultation on TB in prisons. where we had people from around the world, and actually many countries from the continent of Africa presented on what they're doing in relation to TB in prisons. And we had a specific section on our agenda about continuity of care, like how to ensure continuity of care once people are released from prison and maybe they're still taking their TB treatment or even TB preventive treatment. I think what came out of a lot of those presentations was the importance of peer supporters. So these might be people who have actually been in prison themselves. Some of them may have even been healthcare workers. And those people help people in prisons who are being released back into the community complete their TB treatment or provide social support or whatever it is. So I think having peer support is good if that is available in the country context. And of course, it may not always be available. But otherwise, I think you need to refer to the closest health clinic to where the person lives, provide them with some TB treatment, and try and make sure that you can link to that health system so the person actually makes it to that health centre. And if there is some community or civil society or peer supporters who can also, support that person, even if they're 100 or 200 kilometres away from where the prison is, that seems to be very effective in many settings, this sort of peer support. And that's really engaging communities and civil society, actually. So, I think that's what it's about, referring to the health services, but also engaging community organisations, civil society, non-government, who can provide support or peer support networks. Thanks.
Thank you so much, Katie. Fakhriya, would you like to add from the Azerbaijan experience? And also then Anurag and Tom, if you have anything to add, it would be meaningful. Dear colleagues, is it only me who do not hear the dear colleagues?
Yeah. Now, dear colleagues, do you hear? Now,
Yes,
do you
but
hear? Yeah,
yeah.
okay. Okay, the non-governmental organizations in Azerbaijan collects information about prisoners who are to be released. So educational sessions are conducted for them. They are provided with information about the importance of completing treatment. They are talked about the drug-resistant forms of TB. After the release, data
We do
about
not
these
have the English
prisoners are
interpretation
collected,
to relay in
their
French.
place of residence, addresses of relatives, because sometimes it is difficult to find them because they do not always live at their place of registration. So all these data are collected by the non-governmental organizations. After the release, these prisoners are supported to be registered at healthcare facilities, at their place of residence and registration. They are provided with medicines on a monthly basis. And on a monthly basis, monitoring of their treatment is conducted by the NGOs, irrespective of the geography of their residence or former prisoners. The representatives of NGOs visit them where they live, collect the sputum and monitor the progress of treatment. It is done with support of the penitentiary health service, and the doctors of penitentiary facilities collect information. They are controlled. They're still controlled by the penitentiary system, and their treatment is completed with the help of medicines that are provided by the NGOs. And we also monitor the activities of non-governmental organizations during several months, 2, 3, 4 months. We also visit these patients at their place of residence. We ask them about treatment, whether they receive medicines in time. Everything is documented. We also have photo reports and document reports. We try to complete the treatment. Of course, sometimes we lose some foreign prisoners, lose to follow up. So we cannot ensure 100% coverage, but the treatment interruption after release varies from 2 to 3% mostly.
Thank you so much, Fakhriya. Anurag,
Большое спасибо, Фахрия.
I saw your comment, Anurag, in the chat. Would you like to comment on this orally?
Yeah, it's a challenging issue, but again, as people pointed out, we have to have a functioning primary care system to which the patient can be referred back and to ensure continuity of care. I have seen in one of the states in the Indian Union, a local call center which is run by women who provide adherence support at a there's no cost to it, and people constantly communicate with them, and they are free to communicate between 9 and 6 of any day and about their problems as well as other issues. So that has actually ensured very high degree of adherence in MDR-TB patients apart from DSTB patients also. And just to highlight that this continuity of care is not just a problem of the people in prison, but in India we have a large number of people who migrate from one state to another. Because after diagnosis they may just go to another state for employment, and somehow I think TB programs need to factor these movements, and ensure that there's continuity of care. Yeah, thank you.
Thank you so much. I do not see other. There was a hand from Danny. Okay, so now I see another question. So it's Tom. So basically, there were several questions in the chat earlier. Okay, I see Danny. He has his hand on. Okay, Danny, please. I believe Danny is speaking in French. We're waiting for the translation.
Okay, thank you for the floor, Doctor.
Okay,
so
thank
we are
you.
talking about prisoners in DRC. I would like
from
to
DRC.
see your attention.
I watched all the different presentation with deep
It
attention,
was very
and
clear.
everything was clear to me.
I would like to add that.
Dear translators, we have two We have two translators right now speaking at one moment, so please keep an eye on this. We hear two English interpretations. Thank you.
Is it? Alors, dans les situations, we need to see how to work in collaboration to be efficient. We need to work with all human rights organizations to ensure that the need to fight against TB is understood, and we need to have advocacy and activities that will bring authorities to understand the need to take care of TB in prison. This is very important in the fight against tuberculosis in penitentiary system. So I think that we need this collaboration, and I wanted to really highlight it. We need to have a network, raise awareness of human rights actors on the need to fight against TB, so they can understand the importance of working together, working with CSOs. So they are reminding him to be louder. So I was saying, for multisectoral approaches, it is clear that there is a need to have collaboration to efficiently fight against TB. And in the penitentiary system, we highlighted the need to work with the Ministry of Justice. And here also we talk about the need to have active and passive screening practices. And the big challenge in prisons is that we have overpopulated prison systems. And so there's the need to work in collaboration with human rights actors to ensure that advocacy is done on the overcrowdedness of prison, and how we can also fight against abusive arrests that lead to overcrowded prisons, and also advocacy to see how we can have transactional justice practices. And this can be done through awareness raising and also collaboration with other actors. So this is what I wanted to add in the multi-sectoral approaches. Thank you.
Thank you once again, Danny.
I would like to react.
Is anyone from speaker would like
Yes,
to
somebody
reflect?
want to react? There is somebody reacting in the French channel.
Yes, I know, but we have a line, so I will call the Ambroise. So, is anyone? Okay, so there was a clear comment from Tom. Ambroise, please, the floor is yours. Ambroise? Dear French translators, can you translate?
Okay, thank you so much for the floor. I am in DRC, the TB program, and we are currently reviewing and initiating the MTB. This meeting has really been very informative. We are able to see how to accelerate the launching of MAF-TB in DRC, and we have seen the results that are presented here. So I would like to know, what advice will you give us in the target of institution that can help us quickly put in place our MAF-TB, and how we can also make it a dynamic mechanism. So second point, I would like to know, based on different experiences of creating civil society task force, either mention it. So either how are you able to create civil society task force in Burkina Faso, in your different countries? So I would like to know how you put it in place, because currently we are creating or putting in place our MAF-TB in DRC. We have a lot of problem in the penitentiary system, as Danny mentioned it. We have a lot of problem in patient care, mainly drug-resistant TB. So I would like to have experiences on important institutions that we can engage in our MAF-TB to fight against the different social determinants that can actually help address TB in DRC. This is what I wanted to share in this intervention.
Thank you very much, Ambroise. Kerry, would you like to address the first part of the question regarding the institutions that can be engaged? It's like from the MAF-TB perspective.
Yeah, sure. Yeah, well, I think this can be led obviously from the Ministry of Health. And according to, what are the most important drivers and determinants and issues around TB in your particular country, which might so, I've spoken about nutrition, social protection, and prisons. So, of course, there are relevant ministries there, the ministries of justice, the ministries of social welfare, and, there might be a separate ministry for nutrition. So I think it really depends on, what are the priorities in your country, what's driving tuberculosis, and the Ministry of Health can engage with those other ministries, with the evidence in their hand that, this much of our TB is attributable to undernutrition. We have this much TB in prisons. We need to engage. So I think the Ministry of Health can drive that, but they do need to engage with not only, of course, the relevant ministries, but other partners outside of government as well. So that's just just briefly. Yeah.
Thank you so much, Katie. Ida, would you like to address the second part of the question? Ida? Dear translators, can you translate, please?
Yes. All right. Yes. So to add to what Kerry just mentioned, I think that CSOs have a very important role to play in MAF-TB, and they need to contribute so we can really come to an end with TB. So there is a need to engage CSO actors who are working on TB in the different countries. In addition to the ministries that Kerry mentioned, there is a need to engage social action ministries in our different countries, because we have cases where we have refugees, we have immigrants, we have mainly in security concerned areas. We need to take into account those refugees. Julia, with your permission, I can address the second question of Ambroise on the creation of task force in the countries. So I would like to say that, as Julia mentioned, I'm also a member of CSO task force for the fight against TB at the WHO level. And I think that the task force was created through an open selection procedures. And it is composed of different specialties, different members of CSOs, and to members from different countries around the world. Now, at the country level, I know that at the country level, we have associations of former TB patients. And to create the task force at the national level, it is very important to engage the TB patients, invite them for the building of a coalition. And through the coalition, you will be able to create a task force. And it should be mentioned that there are other network like TB Women, which is a movement engaged on gender and TB. And we also have at the Francophone region, we have Draft TB, which is a dynamic for the eliminations of TB in Francophone Africa. So we have a lot of network and TB coalitions at the CSOs level, and we need to identify them at the national level, engage them, invite them for the creation of the CSO task force, because as we said, union always lead to actions and results. And when we have that task force, we will be able to advance the fight against TB. The task force can actually lead advocacy to reinforce CSO's action. Thank you.
Thank you so much, dear Ida. Sekuna, would you like to address the same line of thoughts or a different one? Because I would like to address one important question that we have in the chat from Dr. Sinadaporn from Thailand. So I believe it's for Tom and other colleagues. Can you explain to me a bit more about how can a social protection prevent TB infection? I believe this is very important, very background question, and everyone should understand that. So I would appreciate your comment on this.
Thank you, Dr. Tidapon, for your question. I think with regards to TB infection, I do think there's less evidence available for reducing TB infection once you're exposed than there is for the prevention of progression to disease in people who have TB infection, or indeed improved TB treatment outcomes. But I would say that when we're talking about social protection, it isn't just about money. It's also about improving knowledge, awareness, decreasing stigma, and empowering people and communities affected by TB. And I think the combination of those activities for somebody who does have TB will decrease the time that that person is infectious to other people, the burden of disease that they have in their body, through better access to early diagnosis and appropriate treatments. And I think more broadly for households, they will have a better better understanding in terms of education, infection prevention measures, and indeed improvements to the actual households, be that ventilation or other measures, that will also lead to potentially improvements in living circumstances, decreases in household crowding. And I think a lot of these will also, as Anurag may want to speak to, improve nutrition, and that will thereby strengthen immunity. Whether improved nutrition and strengthening immunity reduces your likelihood of TB infection once you're exposed, I think the evidence is again less strong than the definite link that we know about of improving nutrition, improving immunity, reducing your chance of progression to TB disease, and reducing your chance of bad outcomes if you have TB. Finally, I think much more broadly, social protection can lead to policies or practices, legislation that improve not only household conditions, but also improved workplace conditions. And that may include factories with ventilation, again, overcrowding the accommodation that workers get and enhancing workers' rights. And I think all of those things collectively will have an impact on TB infection. Over.
Thank you so much, Tom, for addressing this. Anurag and other colleagues, would you like to also add to this?
Yeah, so I would echo what Tom has said about social protection, prevention, and infection. Although some studies in the Canadian North have suggested that actually poor diets are also linked to increased risk of infection. So, but these are isolated. We don't have consistent data. But as I said, infection is only a necessary but not sufficient thing to prevent TB. So what happens after infection is more relevant, and there social protection has a big role. And I would really broaden the ambit, mandate of social protection, as Tom fielded, to access to nutrition, access to social services, access to essential services. So once you see that manner, actually, it'll have a big impact. And I just wanted to say that, as Tom said, before there was even a TB control program in the West, because of improved living conditions, working conditions, nutrition, sanitation, everything actually declined, including TB. So while we are at this juncture in low middle income countries, actually we need that broad kind of public health movement to address these issues. And unfortunately, in Africa and in Asia, we have emerged as relatively, independent nations less than a century ago. So there have been immense challenges in all our countries in mobilizing resources. But that the public health movement that happened in the West has to happen here, and not only isolated issues, but putting these together. Yeah, thank you.
Thank you so much. I see the hand from Sekuna. Sekuna, we have only 7 minutes left till the end of the webinar, so I would appreciate your short comment so that we have time to respond and finish the webinar. Thank you. Sekuna, the floor is yours.
Thank you. So for the task force, I think Ida has clearly explained it. Ida is currently expert in creating task force. So I'll now come to comment on the map and creation of MAF-TB. I would like to share experience of Guinea. And as Ida mentioned, so if you go back to the presentation of Ida, all the points are referred to a specific ministry. So the first thing that we need to do when creating MAF-TB is to evaluate the different programs, use the tool that WHO created. The result of that evaluation will now help you plan for advocacy, targeting all the different stakeholders, all the ministries that should be involved in the MAF-TB. And we need to start from that evaluation. And the program should lead to collaboration with CSOs for the implementation of the process. So this is what I wanted to add. Thank you so much.
Thank you so much, Sekuna. So there was one additional question which is not really related to the social protection or nutrition or prisoners, but it was in the chat and not yet addressed. How can young people be meaningfully involved in the fight against TB? Dear colleagues, taking into account your experience and expertise, do you have any advice to Rodolf, who asked this question? So how can we engage young people in I see Anurag, you would like to. Yes?
Maybe Tom has more experience in that sphere with the clubs in Peru and Nepal, so maybe he can
Okay.
answer.
And Ida, maybe you also have some tips from your experience with other civil society organization which you can share. So just 2 minutes for Tom and 2 minutes for Ida, and we are finishing.
Yeah, thank you very much for the question. And I think when we have tried to engage in different settings, younger people, be they children or adolescents or young people more broadly, we have had a lot of challenges, as I think your question alludes to. And some of that has been due to not speaking the same language, talking metaphorically, in terms of not being able to find a platform that actually, for example, the TB Club mutual support groups that appealed to younger people. And one recent study with Ahmad Fuadi in Indonesia, we had to adapt some of these mutual support groups to actually be more online in those certain communities in Indonesia, where younger people did have access to phones and online activities, which may not be the case, obviously, in many other low and middle income settings. But we were able to engage younger people by using a platform that they knew and trusted, but that obviously comes with its own cautions and challenges as well. I think the other thing that's key, wherever you're working with communities that are affected and having interventions that are driven, is that people who you are trying to reach recognize and understand and trust the people who are delivering the intervention. And often that becomes from seeing people who are in your shoes, who may have had TB, who may be a young person as well. The issue that we have with that sometimes is the longevity and the sustainability of being able to have people support in the longer term, because people want to work, they want to go to college and so on. So I think it's an excellent question, one that we haven't fully resolved, but I hope that those are a couple of measures that might be able to help. Over.
Thank you very much, Tom. Ida, would you like to address this as well?
All right. So thank you, Julia, for this question on the engagement of the youth. I think one thing that can be done for impact is to engage former young people who are patients of TB, former TB youth patients in our different associations in the countries. We have young people, we have women. We need to link first with those youth patients who can be advocate to raise awareness among young people on TB. And we've seen in the different presentation that there is a high percentage of TB among people living with HIV. So we can also work on comorbidity between HIV and TB and use that to engage young people. So when we are working on awareness raising against HIV, we can also do awareness raising on the fight against TB. And young people are very open to listening to HIV issues. Then when you are, mainly when you are talking about the availability and use of condom, we can take those opportunities of their interest on those to talk about TB, given that the burden of people is very high among TB patients. So we can use that. Thank you.
Thank you very much. Anurag, 1 minute for the comment. Anurag, you are muted. You are muted.
So I think the school system offers opportunities which we have not really tapped into, communicating information, having a dialogue on nutrition, on these risk factors of alcohol, tobacco use, which actually starts in young age. And there are examples in India of people who have worked very seriously in TB, developing a module for school students. And actually, that they have shown, I don't think there's been a formal study, but just making it a part of the school curriculum, but a more interesting, involved way would be at least would be making a beginning. Yeah, thank you.
Thank you so much. And there is also the document that Kerry shared in the chat. And also there were several comments regarding the World Food Program that strong advocacy effort should be, and also regarding that MAF should be fully integrated to cover all blocks of health sector system. So dear colleagues, our sincere thanks for your participation and for your active leadership in advancing MAF-TB implementation. And we are deeply grateful to our speakers, of course, for the experience and expertise shared today, and our, of course, interpreters, without whom we would not be able to exchange. And we will circulate the recording slides and follow-up materials in the coming days. And also, I would like to say a huge thanks from Monica, who should disconnect due to other overlap activities. So she really thanks to all the speakers and all participants for your participation. And we look forward to see you at the next webinar on December 9. So please save the day. The topic will be related to migrants and MAF-TB in migration. So thank you so much. And you will see right now in the chat the link to the registration for the webinar on December 9. Thank you so much, dear colleagues, and have a great day wherever you are, because I know that for some of you it's already quite late. For some of you it's afternoon or morning. So thank you so much and have a great day.
Thank you.
Bye-bye. Thank you. Thank you.
Bye. Bye.